This is Abdul Khan. This study is performed in conjunction with Matthew LeComte, as well as the other faculty listed below. This study involves the fast scan cardiac MRI in patients with acute pulmonary embolism undergoing catheter-directed therapy. No disclosures. Pulmonary embolism is the third most common cause of cardiovascular demise. It has been characterized into risks including low-risk PE, usually treated with anticoagulation, intermediate risk, and high-risk PE, which are patients who have hypotension or require the use of vasopressors, usually treated with some form of thrombolysis. Thrombolysis has been studied in terms of systemic TPA, which has shown decreased mortality, but has an increased risk of major hemorrhage. And so there's a gray area in treating high-risk and intermediate-risk PE that catheter-directed therapy has been studied for. And our purpose of the study was to study that catheter-directed therapy in some form evaluating the RV dysfunction of pulmonary perfusion. And we felt that MRI would be a good way to go as we can evaluate right ventricular function morphology, which has been evaluated in prior studies and had good results. And so the purpose was to develop a protocol that would allow us to safely perform a cardiac MRI on patients with submassive PE and perform scans before and after their treatments to evaluate pulmonary flow and right ventricular dynamics. And we did this over the course of 2 years. This is the protocol, and we enrolled approximately 5 patients. And our results included no adverse clinical events or aborted scans. We didn't need to use any sedation or contrast. Mean scan time was a little high at 32 minutes. Goal would be, as we perfect this system, to cut that down to less than 20 minutes. The scans themselves were obtained with good quality images. Here's a quick look at the type of images that we obtain and the quality of the images. And as one can see here, the cardiac MR images are vastly superior compared to the typical transthoracic echocardiogram images that are usually performed on patients to evaluate their right heart function. Here we can see some results of our study, and the main thing I want you to focus on is the change in RV ejection fraction, which increased after catheter-directed therapy in almost all of our patients. Additionally, when we looked at pulmonary flow, we were able to evaluate a parameter called time to peak velocity, which, if it was less than 100 milliseconds, would imply some developing pulmonary hypertension and increase in pulmonary vascular resistance. And of note, after catheter-directed therapy, virtually all of our patients had an increased time to peak. And so that development of RV pulmonary hypertension seemed to dissipate. And so in discussing the study, we had no adverse outcomes. We had good image quality. Obviously, it was a very small sample size and a lot more of the study needs to be performed. However, at this stage, we can conclude that we have this protocol that can be safely performed to evaluate pulmonary flow and right ventricular function before and after catheter-directed therapy. And we can continue the study to evaluate any longitudinal data in terms of evaluating catheter-directed therapy as a form of treatment for pulmonary embolism.